Welcome back to Ohio Counseling Conversations, the official podcast of the Ohio Counseling Association, bringing you updates and conversations from around the state. In this episode, we're honored to be joined by Dr. Jessica Headley, an esteemed expert in perinatal mental health. Dr. Headley shares insights drawn from her extensive experience in counseling and specialization in supporting pregnant and postpartum parents. We delve into her journey in the counseling profession, her passion for perinatal mental health, and the integration of evidence-based practices into her work. Join us as we navigate topics ranging from identifying postpartum depression symptoms to advocating for improved access to perinatal mental health services, and learn invaluable strategies for both clinicians and clients alike. And I'm your host today, Dr. Marisa Cargill, a counselor and counselor educator in Northeast Ohio. Let's dig in. Welcome back to Ohio Counseling Conversations. I'm Dr. Marisa Cargill, and today we are joined with Dr. Jessica Headley, and so excited to have her here to talk to us about maternal health issues and how that really works in the counseling profession. So, Jessica, thank you for joining us. So glad to have you here. To kick off the interview, could you share a little bit about yourself and tell us about your experiences in the counseling profession?
Absolutely. Thanks so much for extending this opportunity to me to share my stories and my passion surrounding perinatal mental health. My name is Dr. Jessica Headley, and I serve as president and CEO of Wellness Grove, and that's a growing private practice in Canton that serves individuals of all ages across Ohio. I hold my doctorate degree in counselor education, and I'm a licensed professional clinical counselor supervisor. I'm also certified in perinatal mental health. So, what this certification demonstrates is a commitment to providing advanced treatment and services to mothers and fathers who experience struggles during pregnancy or in the first year following the birth of a child. It also encompasses things like pregnancy loss and infertility. I have been a clinician for over a decade, and among my primary specialty interests are girls and women's issues, gender issues, feminist therapy, and integrating creativity and positive psychology into counseling practice. In addition to clinical practice, I've had the opportunity to teach graduate counseling and art therapy students, to present and publish, and to engage in advocacy efforts. On a personal level, I'm married to my husband and business partner, Sean, and together we have 5 children who range in age from 1 year old to 21 years old.
Yeah, so you really understand some of the parenting experiences that you support your clients with as well.
Right,
Yeah.
on so many developmental levels.
Yeah, yes, definitely. So can you share with us like what initially drew you to perinatal mental health?
So, what drew me to perinatal mental health was my own pregnancy experiences, and I have 2 stories to share. So, my first story is during one of my pregnancies, I experienced severe cramping and went to the hospital for testing. It was confirmed that I had a miscarriage during my first trimester. And during my discharge from the emergency room, I was given a handout with directions to address heavy bleeding and pain. No one asked me how I felt. I wasn't given any resources for mental health and wellness. I would need to then communicate to loved ones that the pregnancy had ended. And I often share with clients that pregnancy loss is like writing a book with all your hopes and dreams for your child, only to go back through all the pages in an effort to try to erase or cross out everything that has been written. This is frustrating and painful to try to do that. And because there's so many thoughts, emotions, and experiences, no matter how much you erase or cross things out, they never disappear. Grief doesn't go away. When I later told my graduate students why I needed to cancel class on the day of my miscarriage, they expressed sadness as well as discomfort in hearing my story because miscarriage continues to be a taboo topic for many people. This was a wonderful opportunity in the classroom for reflection and processing on how students may experience similar disclosures in therapy and how they would like to respond. It was an introduction to clinical counseling course, and I recall that one student ended up completing an advocacy project on educating her local ER about mental health services in instances when patients experience a miscarriage, and that was kind of the spark for my inspiration. So then the story continues. I then had another pregnancy after my miscarriage, And I made it a personal mission to address perinatal mental health and my medical appointments. So I would go to my OBGYN practice and I would ask for a referral list of counselors specializing in perinatal mental health. There was
Mhm.
none. When I
Yeah.
gave birth at the hospital, I asked a lactation consultant if mental health resources were provided. They were not.
Mhm.
Upon discharge at the hospital, I talked to medical doctors about whether I would need to complete a screening assessment for postpartum issues. Again, nothing. And when I would later experience breastfeeding issues and went to a breastfeeding center, they too had no collaborative partnerships or resources related to mental health. When I later returned to scheduling appointments with my primary care provider instead of my OBGYN, the experiences were the same: no resources, no screenings, no discussions.
Wow. Yeah. So you saw the void
Mhm.
that needed to be filled. So this was motivation for you. Wow.
Absolutely. So I decided to pursue my certification in perinatal mental health after these experiences. And then I started to present at state and national conferences and begin writing research. I started increasing my caseload with clients who present with perinatal mental health issues, and then starting to personally create partnerships with medical providers in the area to create more pathways for care.
Wonderful. Yeah. Yeah. So it was a personal mission, but it's definitely something that needs to be talked about more just than in those spaces, but in much larger spaces too. Um, Thank you. Yeah, I think that awareness is really helpful. How in this population supporting women, but also fathers, I know that that's sometimes part of the equation as well. Like that, there's a lot of change happening. But how do you incorporate evidence-based practices into supporting new parents who are postpartum?
Mhm. So there's two evidence-based practices that we typically talk about when working with women who experience postpartum depression. And I'll touch a little bit on working with men and other groups as well, probably as we talk a little bit more. The two approaches that are most commonly used are cognitive behavioral therapy, or CBT, or interpersonal therapy, also known as IPT. Personally, I use CBT from a feminist lens, as this is a very effective approach for major depression. And so, for listeners, obviously many people are aware of CBT, but it's that linkage between thoughts and behaviors and how we can modify distorted thinking patterns to make behavioral changes so that women can cope better and reduce their stress. And so a lot of times in my personal experience, I've worked with moms who experience that thought, I am a bad mother. What's really great about CBT is it's collaborative. It includes psychoeducation. A lot of times I'll integrate relaxation training or assertiveness training, obviously cognitive restructuring, but also looking at strengths, resiliency, and sources of empowerment. Some of the major themes that a clinician would see in working with women who experience postpartum depression are going to be identity losses and shifts, relationship changes and role conflicts, loss and grief, self esteem issues, definitely issues related to self care. We pick up on issues of guilt, and a lot of women will talk about emotional overload. So, when we're utilizing CBT, what's really also important is that it's also effective for a number of comorbid issues that women may experience. And these generally include anxiety, post traumatic stress disorder, and then OCD. That's really my primary approach. But we also see research has demonstrated the utility of peer support groups or group therapy. So at Wellness Grove and at a lot of different places, there's groups for new moms or specific groups for postpartum depression. I'll generally refer clients to those groups, and I'll recommend couples and family therapy. Marital disharmony is one of the most commonly cited non-biological causes of postpartum depression. So really looking at that support system, really looking at areas of growth and then strengthening it and expanding it is really important.
Addressing the system,
Mm-hmm.
right? Infusing that feminist approach. Definitely.
Mm-hmm.
In addition to therapy, are there some like national or community-based resources you typically recommend outside of those groups who are navigating these challenges?
Yes. The nationally based resource that I share the most is PSI, also known as Postpartum Support International. And that's the world's leading authority on mental health. So if you go to the PSI website, you'll see that they offer direct support to families. So they have hotlines, they have support groups, they have individually tailored support groups for women of color, support groups for new moms, support groups for military moms, for example. They also have trainings for professionals, and they engage in advocacy efforts to raise awareness about perinatal mental health being a major public health issue. What's really neat about PSI is that they have volunteer coordinators in every state, including Ohio, and they also are instituted in 36 countries.
Wow.
So that is generally my most commonly used resource and referral for clients. And then as a state resource in Ohio, I recommend POEM, and that stands for Perinatal Outreach and Encouragement for Moms. And they provide peer support groups, generally in the Cincinnati, Dayton, Columbus area, but they also have some online groups.
Great.
They provide
Yeah.
education on pregnancy, and then they also link moms and birthing partners, birthing persons with information and referral information. So that is generally the state resource. Within the community, though, too, I think it's really important that we're linking women with medical services and supports like lactation centers, and then also social supports like job and family services based on their needs or preferences.
Wonderful. Yeah, that's really helpful. And with our listeners, it's something where we like to present some of these topical episodes to give some access or exposure to maybe conversations that they have not been having on a professional level, but maybe they've encountered clients or people in their lives that they're not sure if it's postpartum depression. What would you say are some common symptoms that someone might be experiencing it, and how that's different from like a baby blues maybe experience that new parents have?
Yeah, so when we look at the baby blues, the statistic for the baby blues is that 80% of new mothers will experience the baby blues. And when we look at that, we generally understand that as a normal adjustment to motherhood. So, what we'll see among new moms is patterns of depressive like symptoms. So, we'll see mild mood swings, feelings of sadness, crying spells, stress and worry, irritability, lack of concentration, and feelings of dependency or confusion or uncertainty about this new role and this significant life change. With baby blues, the symptoms tend to arise 2 to 3 days post delivery, and they're understood as reflecting normal hormonal, physical, and psychological changes. Um, it's important that the baby blues really starts to intercept many areas of motherhood. So identities and roles, your sleep, self-care, nutrition, your utilization of social support. It's generally baby blues is mild and transient. And after 2 weeks, we experience a reduction in symptoms of baby blues, if you want to call them symptoms, without therapeutic intervention. When the symptoms last longer, or they significantly impact functioning, that's when the clinician would begin to assess for postpartum depression.
Gotcha. Yeah. So some similar symptoms, but it's the frequency and the impact on functioning that maybe are going to be some of the bigger, um, I guess, telltale signs that this is maybe extended into something more than baby blues.
Absolutely. And something that I often share that's really important for clinicians is that there's no specific diagnostic classification in the Diagnostic and Statistical Manual for Postpartum Depression. So we often, as laypersons, call it postpartum depression, but in the DSM, it is used as a specifier with major depressive disorder, and the specifier is with peripartum onset. So this is a change from the previous version of the DSM that used the word postpartum. And so now the use of peripartum reflects that we see postpartum issues during pregnancy and also in the weeks following pregnancy. The time frame in the DSM is 4 weeks after delivery, but what we also see in the research is that women they have a high risk of a new depressive episode 3 to 6 months after delivery, and that depression can continue for women within the first year.
Yeah. Yeah. So many different changes happening on so many different, the biopsychosocial levels that, yeah, there's so much happening. So how do you approach this, like deciding if it's normal, just adjustment to like, parenthood or more serious mental health concerns like postpartum or peripartum depression?
Yeah, that's a really good question. And as you kind of had mentioned too, we're going to be looking at the severity and we're going to be looking at the length of time. But from a feminist lens, we're also going to be looking at what is normal, right? And so when we look at the transition to motherhood, traditionally beginning in pregnancy, we know this is a significant life event. And in the United States, the discourse surrounding mothering and motherhood is rife with stories of celebration, right? And joy. Like, this is a wonderful experience. I should be so grateful that I'm having a baby. This is the happiest moment of my life. These are the stories that the United States, the dominant discourse, shares with us. That's what's considered normal. But what we really know is that many women experience struggles related to their bodies, their identity, expectations, infant bonding, relational support, and coping. And you had previously mentioned dads. What we know from the statistics is that 1 in 5 women will have depression or anxiety during pregnancy or postpartum. And the statistics for dads is 1 in 10. So one of the things is important to keep these statistics in mind because they're high. So one of the ways that we look at, okay, is this, a quote unquote normal adjustment, or is this a clinical issue, is obviously we're going to want to hear women's stories. We're going to want to keep in mind these statistics. We're going to want to integrate screening assessments, and we're going to want to engage in comprehensive clinical interviews.
Hmm. Yeah, and you mentioned earlier like CBT and IPT as like evidence-based treatments or approaches to working with new parents, maybe coming through some perinatal mental health issues. What are some of those assessment or screening tools that you would use to evaluate during pregnancy or even in the postpartum period?
So there's a handful of screening tools. The most commonly used tool is the Edinburgh Postnatal Depression Scale, or the EPDS. And so that's a 10-item self report. It looks at emotional and functional factors, and it can be used during pregnancy. Another commonly used screening tool that many clinicians use is the PHQ-9, or the Physician's Health Questionnaire. Um, However, one of the things about the screenings that's really important to know is that they often generate a certain number of false positives. And so the recommendation is that these be used as collateral data, and the diagnosis of depression must be confirmed by clinical interview. And so I like to talk about really important pieces of clinical interviews because that is really going to be the most important source of our clinical data. So some of the things that I mentioned for clinical interview is it's important to talk about pregnancies and the nature of pregnancy. So inquiring about the birth story to include pregnancy and delivery for past pregnancies. We want to discuss perinatal loss, adoption, termination. We want to ask questions such as whether pregnancies are planned or unplanned, unwanted or wanted. If there's experiences with infertility, what breastfeeding is like. It's important for us to discuss the mental health and medical history. We want to inquire about family mental health and experiences of trauma and substance use. We want to inquire about medications. We want to ask about PMS and thyroid issues, particularly.
Okay. Yeah.
Safety would be like another big concern, and supports. Spirituality would be another, and then changes and losses over the years. So I would say really a holistic assessment, which we're trained as counselors to do, while also ruling out things. So some of the big rule outs that we want to look at would be thyroid issues, anemia, trauma, side effects of medication, and then alcohol and drug use.
Right. Yeah, having this holistic lens, big picture view to understand uh, some of the variables that could be contributing or some of the things that maybe we could help rule out. Yeah, that's really helpful. So I think it speaks to a lot of like what we teach as educators, but we've learned as students that like we're always to be assessing, right? And that yeah, it's great to use these screening tools, and more often those are like a foundation for further conversation.
Exactly.
Yeah, wonderful. So you mentioned some of the medical concerns that maybe we would be ruling out or assessing for. Tell us more about like maybe clients who are seeking medication or who might require medication as part of their treatment plan. How do you approach integrating that with counseling interventions
Mm-hmm.
for mental health?
I think this is such an important topic, and I'm so glad that you asked this because this comes up a lot in therapy. One of the things I share with clients is that psychotherapy is an effective treatment even for severe postpartum depression. So rather than the use of medications as a first line treatment, it can be reserved for more severe depression that's not responsive to counseling. Most of the common presenting symptoms requiring medication are depression, anxiety, and insomnia. So it's really important to look at sleep patterns and how that's impacting overall mood and functioning. When we're discussing psychopharmacology with clients, we want to make sure that the client is fully informed so that there's informed decision making that includes a risk benefit analysis. And these are always made on a case by case. So we're always looking at what when a psychiatric condition necessitates psychopharmacology and like what those risks are. It may be that the risks are higher for not treating the mental health issue for mom and for baby. So one of the best things that we could do is coordinate with our prescribers to discuss medication plans. And as part of our role, we want to ask what's worked in the past, what works now. We want to discuss the side effects. And then we also want to keep in mind that when women present with issues such as bipolar disorder or any psychotic illness or postpartum psychosis, that's generally always going to require continuous medication management. So it's so vital that we give education to our clients about working with an experienced reproductive psychiatric provider. There's generally a lot of concerns that women talk about with medication management, such as miscarriage, congenital abnormalities, autism, and ADHD. A lot of these are not true risks. So I think it's also important that we make sure that education is provided to women about the real risks and some of the falsities that are spread about the use of medication management.
Right, right. So it's a psychoeducation component, but also like a collaborative approach with those prescribers to ensure that like needs are being met, people are understanding not only the client, but that the collaborative like prescriber might understand, some of the risks that you had discussed, kind of working together as a team approach to helping support the clients. That's
Absolutely. And I would say too, there's this push for specialty care, right? So, specialty care in counselors who specialize in perinatal mental health, but also holding the same standard to prescribers and
mhm.
our general practitioners.
Yeah, yeah, making sure that they understand the experience more fully, not just like a surface level conceptualization.
Hmm.
Yeah,
Yeah.
well, yeah. I think as counselors, we love collaboration, and that's sort of at the core of some of our professional identity values. And I think it's important for us not only with prescribers, but with organizations, communities, and recently, and it's actually been, I guess, recently more discussed, but not necessarily only recently. Ohio's been in the spotlight for really poor maternal health outcomes, especially for Black women. I'm curious how you think clinicians and organizations can better advocate or collaborate for improved access for mental health services at both local and national levels.
Hmm. I have always found this to be a very interesting topic. And there is now a stronger body of research related to postpartum depression help seeking behaviors. And what we're finding in the research is that women themselves may be the biggest barrier. And so women are likely to not have knowledge about effectiveness of services. They may lack knowledge about postpartum symptoms and available supports. And there's understandable fears of losing their children or being labeled mentally ill if symptoms are shared. So another kind of area that we look at too is the social support networks. And so really having people around them that may say, oh, well, this is just the baby blues, or minimizing, this is normal and this is to be expected. You're going to be just fine. And so I think that we play a really important role in increasing the knowledge base to other providers, other community supports, so that we can help educate women about their symptoms, and that we can also promote an understanding that receiving help in terms of counseling, it could be for remediation of symptoms, but it can also be for wellness. And if we can get women in the door for wellness, just imagine the impact that we can make. And definitely there are disparities for Black women, there are disparities for Latino women, and there's also some other high risk groups. Some of those high risk factors are new mothers who are young or unmarried, women who have less than 12 years of education, women who've experienced multiple stressful life events, so traumas, and women who have complicated pregnancy, so maybe low birth weight for infants or being part of NICU services. So it's really kind of important that there's a lot of groups of women that are underserved, and that those doors need to be opened for them.
Mm-hmm. Yeah, making sure like that we are then taking like active advocacy roles outside of just like appointments and sessions with clients, but making sure other people know so that maybe those barriers to help seeking are, decreased or eliminated. Yeah.
Right.
Wonderful. What would you suggest? We have some newer professionals or sometimes just professionals who are looking to explore other areas of the counseling field, but what would you suggest for folks who maybe are looking to seek more knowledge or certification in this area?
So I would say there's two big places that I generally recommend. So we talked a little bit about Postpartum Support International. They provide trainings for certification. So you can get the national certification and be part of the national registry. And they also have certificates for treatment of anxiety and different topics as well. So that's a really great website to go to just learn about the professional trainings and things that you can earn. And then the second that I generally recommend is someone's really interested in perinatal mental health is looking at the IPT Institute and then getting certification in IPT. And sometimes when you go on their website, you'll see that they have specialty trainings for perinatal mental health. It's generally just once a year, so you have to keep a lookout, but it can be tailored around that issue. So I always say just keep a lookout for that.
Yeah, great. And we'll be sure to link those in the show notes too, so folks can find those pretty easily. But yeah, thank you. I think that's great. I might be checking it out after this interview. So shifting gears just a little bit, when we come back to client focus, are there any specific cultural considerations or practices that we as clinicians should be aware of when we're giving this type of mental health support, perinatal health, mental health support to women from different ethnic or cultural groups?
Yeah, there's so many considerations on the medical side and then also the counseling side. So when we look at it in general, there is so much stigma and trauma and care inequalities for persons of color who are mom and birthing persons. And so it's really important for us to create environments of care where there's safety and genuine support. Some of the research shows, a lot of the research shows that Black and Latina women, for example, are less likely to initiate postpartum mental health treatment. And they're also less likely to have follow-up visits with their providers. And so again, we go back to this collaborative care model with counselors working with medical providers so that we can provide full support for women. Some of the other things that are really important is that there's higher mortality rates for Black and Latina mothers, and that there are some factors that contribute to higher rates of mortality and higher rates of perinatal mental health issues, such as racism, unemployment, exposure to violence, gaps in medical insurance. So, whether there's insurance coverage, lack of representation in the medical system, and higher risk of complications. And so really looking at those things, it's really important that we step back and really assess, what insurance coverage do you have? Like, do you anticipate a lapse? Or let me pair you with a provider who has a similar background to you, right? And so that there's that comfort, and so that we can make sure that sessions are maintained across time and that you have a general safe space for yourself. So some of the pointers that I generally give are, first and foremost, listening. Creating a space for women of color, where clinicians are open and active listeners, and where we refrain from being dismissive about women's experiences.
Yeah.
And then two is implementing and prioritizing postpartum education and support during our counseling sessions. And so really utilizing standardized screening assessments and sharing those results, keeping an open and transparent environment, and providing clinical recommendations with the why. Why we're recommending that clinical recommendation, and making sure that it comes from a place of care, right? And concern for the client. And then really thinking about partnering with organizations and groups that focus on services for women of color. And so when we're recommending support groups, can we find a support group that really relates to someone's racial or ethnic background, right? Because that's going to create alliances and rapport building that's really necessary for the needs for support, right? And those strong support systems. And so really taking a look, sometimes there's larger organizations. One example would be Black Mamas Matter Alliance. That's a national organization, but then also looking at what's offered throughout the state or locally.
Right, right. Yeah. And it sounds like some of that is then helping foster connections for our clients, whether they remain our clients or not. Maybe it's connecting them with someone who has more of a similar background, racially or ethnically, and um, beyond that, also helping foster connections that they have in the community or with other mothers from a similar background, to have that support, feel less alone. But I really like what you said, because as like a counselor educator, I'm always like, hey, we underestimate the value of just being a good listener and validating people. And I think that goes a long way with clients. And literally have had clients when, they've had past therapeutic experiences, right? Talk about um, that that's what they want. Like if they didn't get that in a different therapeutic experience, that what they're seeking is someone to listen, and that maybe they did like that about past counseling experience, like they liked being heard and having space to share their experience and receive support with that. So yeah, um, I know supporting clients with perinatal mental health challenges is pretty heavy sometimes, emotionally demanding, maybe even physically exhausting in some ways, because it's heavy, right? When you think about that experience, what strategies would you recommend for clinicians who are working in that group to prevent burnout, prioritize like their self-care while providing this type of support?
Self-care is so important, and preventing burnout is something that I know is on the minds of all of us as counselor educators and counselors providing services. What I like to say is important to build a self-care routine. And it's also important to examine our beliefs about self-care. So sometimes clinicians hold the view, I'll do that later. or there's something more pressing right now. I need to be here for the client, or I have this to-do list I need to accomplish. And really making sure that it's not just something that we do, that it's part of our lifestyle. And so I like to think of, what are the self-care practices that I do before work, during work, and then after work? And a lot of examples of self-care practices, might be mindfulness or movement. I enjoy self-compassion exercises during the day, or just activities where you unplug. I love personal check-ins with myself. How am I doing? Maybe after a session, where am I at? Do I need to take a walk around the building? Asking for consultation and support from your peers, whether it's within your organization or outside. My two favorite things are, make sure you take vacations.
Yes.
Don't I feel like that is a topic that we all need to talk about. Take a
Yeah.
vacation, right? And another one that I really enjoy talking about is integrating humor into your work. And I was talking with a colleague earlier today about, you know if someone took away laughter from my job, if I had a rule that I couldn't laugh at work anymore, I'm not quite sure I would love what I do. And so even in the most difficult of times, is finding that way to integrate humor and laughter and joy. But on a bigger picture, I also like to look at burnout and self-care is not just an individual problem, but an organizational one, right? And so we may need support in promoting work-life balance. We may need to have conversations with our organizations and where we work about our schedules, about our caseloads, about the types of issues that we see on our caseloads, about our work environments, and to really look at burnout isn't just a solo problem. It's a group problem. It's something that we should all care about for ourselves, but for everybody around us. And so I also like to say, let's look at the big picture. What are some changes that might be possible, or that we might be able to create possibilities for?
Yeah, I love that. You mentioned earlier, like some of your own experiences, and I appreciate your vulnerability in sharing that. I think that that makes it even more human, and that's sort of what was your passion in learning more about perinatal mental health. What has it meant for you to bring your own experiences into the professional space?
It has meant the world, because a lot of times when I'm presenting at state and national conferences, the sessions on perinatal mental health that I present or co-present with my colleagues are the only one of their kind at the conferences. And so, bringing my personal story into such a wonderful space with my colleagues is so inspiring. And to be in rooms of people who say, I'm so grateful that we all get to sit together for this presentation and discuss how we can improve care, continues to be a source of inspiration for me. I find that there is such a lack of training on an educational front, and that there's such a dearth of services, specialized services, right? And that we also need more clinicians that are interested in diverse clinicians. We need clinicians of color and male clinicians, and clinicians who have disabilities, and clinicians with military experience. All of these experiences, whether they're demographic variables or personal and professional experiences, to come together as like a call to action to serve this need, because our clients need that too.
So, like for similar, like for people who maybe had similar experiences to you, pregnancy loss, or other maybe significant lived experiences, any advice you would share with them um, to inform, like that they have power in caring for others with similar experience?
I would say, I need to think about this one, Marissa.
Yeah.
You're going to have to give me a minute. What advice would I share? Okay. What I would share with okay. This is so personal. It's a personal question, right? And so um, okay. What I would share with clinicians is that their stories hold power, right? And so our stories hold power within therapy sessions as appropriate. So I'm a feminist counselor, so self disclosure is part of what I do. It's part of who I am as a therapist, and I use it in ways that benefit clients in therapy sessions. And so my story can matter in a counseling session, but my story can also matter when I'm mentoring new clinicians interested in perinatal mental health, and when I'm sharing research and I'm sharing my clinical experiences with others who are providing care. And so I think, in a nutshell, what I would say is that stories have power. And the more that we share our stories, the more change that can come from those.
Yeah, I got goosebumps. Like, we know the show's title now. Stories have power.
Mm-hmm. Yeah, that's
Yeah,
what I would say. Mm-hmm.
yeah. Um, I know that we mentioned fathers. This is like a hard turn here, like earlier. Is there anything like you feel like maybe we need to touch on in terms of like also supporting fathers who new fathers?
Mm-hmm. So supporting new fathers, that is really important. And it's really important to be sensitive to the nature of gender. And so, what we see in practice and the research is that fathers are not necessarily receptive to being told that they have postpartum depression or being asked to join postpartum depression support groups. So, generally, with fathers, we do provide psychoeducation. But if we're doing services like creating a support group, we might create a support group for new dads. And we may touch on the topic of postpartum depression, but it's not going to be the title of the group. And so there is that stigma that we need to address with new fathers. And it's also letting them know that debunking the stereotype that postpartum depression is only for women, that really men experience this as well. And there's a 50% chance that if in a married opposite sex couple, that if a wife has postpartum depression, there's a 50% chance that her partner will as well.
Yeah, that's interesting. Yeah, I did not know that. So, okay. Any closing thoughts, messages you feel like you'd like to share with the listeners regarding the importance of perinatal mental health and how, we as counselors support people through this transformative time?
I would say that one important thing to consider, and I know we touched on it lightly, is the prevalence of co-occurring issues. And so really making sure that we're looking at a comprehensive assessment, that we're looking at issues like anxiety or OCD or trauma. Also, we need to assess for self-harm, and we need to understand that this presence of self-harm ideation is a risk factor for suicide, and that suicide is the second leading cause of death among postpartum mothers with depression. So when we start to see presence of postpartum psychosis, which is 1 to 2 out of 1,000 women who give birth, uh, this is devastating. It leads to devastating consequences for mothers in terms of their safety and their babies. And so it's really important to learn about postpartum psychosis, which includes hallucinations, disorganized thinking, mood shifts, paranoia, and treat that as a medical emergency. And so I think there's a lot of training and work that can be done in terms of looking at these comorbid issues and also safety concerns.
Hmm. Yeah, that point is well taken. Yeah. So the risk is part of the assessment, like that comprehensive assessment process, because it's significant impact. Yeah. So in closing, we ask this question for all of our guests. The name of the podcast is Ohio Counseling Conversations. So we always want to know from our guests, what important conversations do you think counseling professionals should be having with each other or their clients in Ohio?
Mm-hmm. Well, obviously, at the top of my list today is perinatal mental health, right? And so there's a call to action here. I just like to say plainly, we need to do better. And, moving beyond perinatal mental health, the things at the top of my mind lately are really social and cultural events like Medicare recognition, COVID-19, the counseling compact, all of those things and how that impacts counselors in the counseling profession. And I'm particularly interested in lately in learning about perspectives and really views about the significant shortage of mental health professionals. That includes counselors and some of the issues that deepen the shortage. So looking at low pay and increased workloads and counselor burnout. Almost half of the United States lives in a mental health workforce shortage area. So there are these very big disparities, and I'm really interested to hear some of the ideas or solutions that people have, whether they're micro or meso or macro, right? And some of the things that we can do to help.
Yeah, yeah, definitely. It's a big conversation, right?
Mhm.
But and much needed. Let's identify how we maybe improve this, not only for the profession, right, and strengthening our profession, but also for the people that we serve.
Absolutely. There's a lot to be done.
Yes, yes. Well, this was a wonderful, very informative conversation. Jessica, thank you so much for joining us. And thank you all for listening. And we will catch you next time on Ohio Counseling Conversations.
Thank you so much.
Ohio Counseling Conversations is on a mission to make this podcast meaningful to you, and we can't do that without your help. A feedback form is linked in the show notes for this episode and is also available on the OCA Linktree. If you have any recommendations for topics or guests or any other general feedback, you can let us know by using the form. We welcome your thoughts so that we can continue to develop the podcast and grow as creators. If you are interested in joining the team or being a guest, you can also reach us by emailing ohiocounselingconversations@gmail.com. We value your insight. Thank you so much for listening.
If you enjoyed this episode, please make sure to follow us so you can stay up to date with Ohio Counseling Conversations online and wherever you listen to podcasts.
This podcast is brought to you by the Ohio Counseling Association's Media, Public Relations, and Membership Committee and its podcast subcommittee. This podcast features original music selections by Elijah Sototer-Wood and our closing song, Accretion Discotheque by Who AD. Views, beliefs, or references mentioned in this episode do not constitute an endorsement or recommendation by the Ohio Counseling Association. The views expressed by guests are their own, and their appearance on the podcast does not imply an endorsement of them or any entity they represent. Views and opinions expressed by guests do not necessarily reflect the view of the Ohio Counseling Association or any of its officials. Thank you.